Good afternoon, everyone, and thank you for the lovely introduction, Wafa. So it's a pleasure to be here with all of you celebrating World AIDS Day. And as Wafa mentioned, I'm from the New York City Department of Health. And over the next 20 minutes, I hope to cover two big items. First, I want to give you an update of the latest surveillance data, which are actually hot off the press. They were released last week, a few days ahead of World AIDS Day. So I have the latest numbers for New York City. And then second, I'm going to talk about some work we're doing around ending the epidemic. This is a 5-year initiative within New York City designed to bring infections down to record lows, and we're making very good progress. And testing is sort of one of the key pillars of that initiative. So I'll talk a little bit more about that work. All right. So to get us oriented to the national epidemic, this is a map of the United States showing new HIV diagnoses for every state for 2017. I got these data from CDC. And overall, there were, in 2017, 38,640 newly infected or newly diagnosed individuals, giving us a rate of 14 newly infected folks per 100,000. So the case rates are actually divided into 4 groups or quartiles, and what you can see is the darker the color, the higher the burden of HIV within that particular state. And I think what stands out immediately is that the southern part of the US has the highest burden of newly infected individuals, newly diagnosed, I should say, which is somewhat a proxy for newly infected individuals. So places like Louisiana, Florida have 27 newly diagnosed individuals per 100,000 population. Georgia has 30. So really high, although Washington, D.C. has the highest rate at nearly 54 newly infected people per 100,000. So D.C. has had really high numbers for a few years now. With that said, I want to point out New York State. And although the number is much lower at 16.4, this still falls into the highest quartile. So HIV is still a big concern here. We're still diagnosing a lot of people. We were, of course, historically the epicenter for the epidemic, but that has not necessarily gone away. We're still dealing with a lot of HIV here. So zooming in on New York City, this is a figure that we show often. It shows the history of our HIV epidemic from 1981 all the way to 2017. And what you can see is that we've made tremendous progress. So new AIDS diagnoses is represented here by the red line, and HIV-related deaths by the green line. And we saw a peak in the early to mid 1990s, and this rapid decline that you see here was a result of highly active antiretroviral therapy. In addition, we know that harm reduction strategies such as expansion of syringe exchange programs made a big impact there as well. So as a result, the total number of people represented here by the blue bars, the total number of people living with HIV has gone up as people are successfully living with the virus and living long lives. In 2001, we started capturing both AIDS and non-AIDS cases. Before, you can see we just captured AIDS cases. In 2001, we in terms of surveillance, we started capturing both. And so that's the black line here, and that's the number we follow very closely, as well as the AIDS cases. But that number overall has gone down as well. And in 2017, we had a record low. We've had a few record lows for the last several years, but we had a record low of 2,157 newly diagnosed individuals, which gives us a case rate of 25.3. So I showed you the national trends. So New York City is still a place where a lot of HIV is diagnosed. When you look at those newly infected or newly diagnosed individuals from 2017, what you see are tremendous disparities with certain subpopulations being disproportionately affected. So specifically males, blacks and Hispanics, people in their 20s, MSM, men that have sex with men, and people that live at high levels of poverty, represented here by percent of the federal poverty line, are individuals that are getting infected at a disproportionate rate. So this is something we're aware of. The disparities have been intractable, and so this is something we need to work on and part of our ending of the epidemic efforts are focused on that as well. So this slide shows you trends in new HIV diagnoses by transmission category. So the blue line represents MSM, men that have sex with men. The red line are individuals who are infected through heterosexual contact, and then the green line, individuals who are infected from injection drug use. And what you can see overall is since 2001, we've seen steady declines among individuals reporting heterosexual contact as well as injection drug use. In fact, the IDU group, we're getting very close to zero, which is really impressive. Though, of course, we're monitoring this number very carefully given our current opioid crisis. So we're tracking that. However, among MSM, from 2001 all the way through 2014, not much progress, really almost flat line, even peaking a bit in 2008. Luckily, in the last 3 years, we've seen tremendous progress, an overall 25% decline in this subpopulation, which we're tracking closely. We think this is due to the expansion of pre-exposure prophylaxis, as well as hopefully our ending of the epidemic efforts are playing a role here. So we do look specifically at this subpopulation. So in this slide, it represents sort of our biggest success, which is the rise and fall of mother-to-child transmission here in New York City. We've made tremendous progress. You can see we had, so the blue portion of the bar, so these are total births of infants born to HIV-positive mothers who are, the infants are positive, perinatal transmissions. So we had a peak in 1990 with 340 newly infected infants that year alone. And the blue part of the bars represents infants that are still alive as of today, or as of the end of 2017, I should say. And the red line, or the red portion of the bar is unfortunately those infants that have passed away. And so over time we are seeing increased survival, but most striking, in 2015 the numbers went down rapidly, and in 2015 we actually had 0 transmissions. Unfortunately, in 2016 and 2017 we had 1 transmission each year of an infant coming positive. So we're hoping to get it back to 0 so we can say we eliminated mother-to-child transmission. And the success, in the box here you can see some of the milestones that led to the success. You can boil it down to 3 big, interventions. The first is routine testing in the mothers during pregnancy, as well as their infants at birth. And so HIV testing is part of the neonatal screen here in New York State. Additionally, aggressive treatment of the mothers during their pregnancies, and as well as at delivery, if needed. And then finally, pre-exposure prophylaxis in the infants, if they're exposed to, an HIV positive, their mother's HIV positive. And so these 3 big items have sort of served as the model for our own ending of the epidemic initiative, the current initiative that I'll tell you a little bit about. So some of the themes will repeat. So going back to new infections over the last 5 years, when you stratify by gender, what you see again is that men represent 80% of our epidemic, women 20%. In both groups, we've seen declines of about 23 to 26% over the last 5 years, a little more in the men than the women. These pie charts show the racial ethnic disparity that I mentioned earlier in our epidemic. So men are represented by the pie chart on the left, women on the right. And what you can see is that for men, for 2017, black men represented 38% of new infections, Latino men 38% as well. So all in all, 76% of new infections among men were among men of color. For women, that number is even higher. Black women represented 61% of new infections among women, and Latinas represented 27%. So 88%. So the overwhelming majority of our infections among women are women of color. So there are significant disparities here. When you look at transmission risk for each gender, for men, as I mentioned, MSM represents the vast majority of newly infected folks. Women report heterosexual contact, 67%. And we still have in each group a sizable group, 20%, for whom we have unknown risk. And we're unclear on what, potentially stigma, disclosure of what their risk is could be at play here. So this is a map for New York City, similar to the map I showed you for the United States. It's a heat map showing new diagnoses, the rates of new diagnoses across all the boroughs. And again, there are geographic disparities as well. And historically, what we see is that HIV in New York City tracks with poverty. So places with high poverty tend to have the highest burden of HIV. And so you see, even with, so this is the case with mortality, with prevalence, as well as new diagnoses. So in terms of new infections, the Bronx was poorly represented, as well as northern Manhattan, central Harlem in particular, parts of Brooklyn, northeast parts of Brooklyn. And then kind of the exception around the connection between HIV and poverty is this Chelsea Clinton area, where we do see a lot of HIV, but I wouldn't say it's a high poverty area. But we know that a lot of gay men reside there, and they are a group disproportionately affected by HIV. So in order to address these disparities and the burden of HIV in New York State, in April, I believe it was 2015, Governor Cuomo released this blueprint detailing a strategy to end the HIV epidemic. I do have to say, it involved input from clinical providers, community members, public health officials, so it really entailed a lot of collaboration from the entire HIV workforce and the community. But it basically details a set of recommendations designed to end the epidemic, which is defined as bringing new infections down to record lows, such that new infections go below the mortality rate and would result in a declining prevalence. So as I showed you on the figure before, the total number of people living with HIV has gone up every year, but the goal with ETE, or ending of the epidemic, is to get the prevalence to start declining. So there are three big, the strategies there could be summarized as the three big pillars of ETE. The first is to identify all persons with HIV who remain undiagnosed. So this is all about, the focus of today's talk, knowing your status, getting tested. The second is to link, retain, and ensure people who are diagnosed are getting into care and starting ART, antiretroviral therapy, and achieving the goal of viral suppression. And as often mentioned, it's good for their own health. It reduces onward transmission as well, and treatment is prevention. That's really critical. And then finally, it's to facilitate access to pre-exposure prophylaxis for those who are HIV negative but at risk for infection. So I'll focus on some of the initiatives focused around the first item, which is increasing knowledge of status for testing. So at the health department, there are a couple of strategies to increase testing. The first is that we support a two-tiered approach to HIV testing through a variety of mechanisms. First is to routinize HIV testing within healthcare settings. And we're lucky here in New York State, through a lot of advocacy, we actually have a policy mandate that healthcare providers offer HIV tests annually to those individuals who are 13 years of age or older. So this is the routinization of HIV testing. And it's done through an opt-out strategy, which means the test is done and the patient is informed that it's going to be done unless they opt out. And there's no longer a requirement for a written consent, which historically has been very burdensome and has limited the number of tests that have gotten done. So this is a huge win for us. Some of these changes happened in the last few years. And many hospitals and clinics have also implemented electronic prompts into their electronic medical records, which really make this process very routine, such that anyone going to a hospital or ER should be asked whether or not or that they're getting an HIV test and they have the option to opt out. Additionally, we also support targeted testing for priority populations. These are groups, as I mentioned already, that based on our surveillance data have a high burden of HIV, including MSM, those who inject drugs, those who are in stably housed sex workers. So we do support CBOs through contracts to do some direct outreach, mobile testing, as was mentioned. And so those are, we do a two-pronged approach. Additionally, we support new HIV testing technologies such as the 4th and 5th generation combination antigen antibody tests, which detect infection much earlier. And so these are great, and a lot of we work with hospitals and clinics to promote them and ensure adoption. And innovative testing strategies such as home testing, which historically has been very controversial, but we are promoting it, and actually we go to venues like bars and distribute some. We also advertise on social media platforms, dating apps. You can see this is like one of the banners from maybe Grindr or one of those websites. And so we actually give gift cards, which I have an example. And we actually have a few kits, and then we have these gift cards well, not gift cards, but yeah, you can call them gift cards, but you can go to Walgreens, take this there, and it's a $50 value. So the kit is expensive. That is one of the barriers right now. But this allows anyone to get a free test kit. So we have a few outside on the table. And then finally, we believe community engagement is really critical. We have a team at the New York City Department of Health, the New York NOS team, which basically brings together providers, community members, and hosts testing initiatives throughout all the boroughs. Each borough has its own New York NOS team dedicated to it. It started in the Bronx NOS, so they host a lot of these testing events. And we've had a lot of success increasing testing in the Bronx, as well as some of the other boroughs. So how are we doing? Slow but steady progress. These are data from the Community Health Survey, which is this annual cross-sectional phone survey that's done by the New York City Department of Health to assess the presence or prevalence of chronic diseases, behavioral risk factors. And so there is a question about ever being tested for HIV, any tests in that person's lifetime for HIV. And what you can see is in 2007, 55.9% of the sample, and usually there are about 10,000 people sampled, so they had received an HIV test at least once, and that's gone up to nearly 65%. So it's slow and steady, but it is increasing every year. So we want to push the numbers even higher, of course. We also track the percentage of people living with HIV, PLWH, who remain undiagnosed. So people are walking around, have HIV, and we just don't know it. And so there are two methods that we've used to estimate this number. The first is there's actually a CDC algorithm that uses the CD4 depletion method. They look at declines in this CD4 count and other variables to estimate it. So it's an estimation. And for 2017, using that model, about 7% of people living with HIV don't know that they're positive. And that's what we use to, craft that number on the care continuum. So here's 100% for PLWH, 93% are believed to be diagnosed, 86 retained in care, 80 prescribed ART, and 74% achieve viral suppression. So we want to drive these numbers higher, but it's pretty amazing compared to the rest of the United States. We also conduct Seraph Surveys periodically. So Lucia Torian from the Bureau of HIV just published in the AJPH. They partnered with Monty colleagues to test specimens from people visiting their ER, nearly 5,000 people over the course of time, and they found that 4.8% of those individuals were not known to our system, either to Monty or within our own surveillance registry. So it's a much lower rate, well, slightly lower than the 7%, but we know the Bronx is probably one of the best, most tested boroughs. So that's great progress. And there are plans to do Seraph surveys in other boroughs as well. And then finally, based on CHS data, there are other, in terms of ever being tested, we do have disparities. Queens, Brooklyn, Staten Island, we need to do better in terms of testing. And then this, I won't belabor the point, it's really similar to the figure Wafa presented. It's showing our status neutral approach to HIV care and prevention. that it was designed with an idea or an interest in reducing stigma and promoting healthcare access and utilization. So it all starts with the HIV test. If the person's positive, obviously they get, ideally get engaged in care, start ART, achieve viral suppression, and that's the treatment engagement arm. If they're negative, we don't just let them go. We assess their risk, determine if they're a candidate for PrEP, get them engaged in PrEP treatment or other prevention strategies. So there's a toolkit of prevention. PrEP is one of them. And so that's the prevention engagement arm. So the focus becomes less so on the person's HIV status and more so on their engagement in healthcare. And then this is second to the last slide. We're doing a lot of work, particularly this year, within the Bureau of HIV to reduce stigma. That's become kind of like our big focus this year. As such, we're promoting the U=U messaging. U=U means undetectable equals untransmittable, or essentially treatment as prevention. But based on recent research, the idea, and this is the idea, that a person who has HIV who's undetectable does not transmit HIV sexually if they achieve viral suppression. And so there's just so much robust data around that. And so this really social marketing campaign has started, U=U. And we think it's a potent stigma reducer for both people living with HIV, their partners, and the public. We also think that by reducing stigma, there will be a greater willingness to get tested. People will hopefully stay in care, disclose more, have a better quality of life, and more social support. So in conclusion, we have an old epidemic that's declining, but rates of HIV diagnoses are still relatively high and disparities persist here in New York City. Our ending of the epidemic initiative is designed to address that and reduce both incidence and prevalence. And certainly HIV testing is the gateway to make that happen. We do know testing rates are increasing steadily. We want them to go up even higher. But we're doing this through both two-pronged, routinized, targeted strategy, promotion of anti-stigma messaging, and a lot of community outreach. Thank you.